Hello, I'm Jean Pete, and I welcome you back to our show, Better Living. Better Living is brought to you by the Homestead Hope Foundation and is sponsored by Homestead Hospice, where commitment to education and premier hospice care helps patients and families through life's most important journey. Thank you for joining me again this week. This week, I am here with Dr. Shamir Bhikha. How did I do?
Perfect.
And Dr. Bhikha is here today from Ankle and Foot Centers of Georgia. I read on your questionnaire you have centers everywhere, but you work out of the Alpharetta, Georgia office?
Exactly. Our group itself has 21 offices throughout the, I would say, metro Atlanta area. We're primarily in the south, but we are now expanding into Alpharetta as well as Cumming, Georgia. We have 4 surgery centers within our group, as well as 3 physical therapy centers. We have, I believe, a total of 4 MRI centers now. So our main goal is to be able to keep everything within in-house so that we can ensure that each patient has the right quality of care rather than trying to work with a physical therapy center that may not have adequate communication with the doctor, or a surgery center that doesn't have all the materials that the doctor may need.
And we'll talk about costs later, but I would assume that can help keep costs lower, too.
It definitely can. All 21 offices and all 23 doctors cover majority of the insurance companies. We don't take in particular Medicaid as well as the new Affordable Care Act plans, but majority of the insurance plans are covered, and it's really a matter of us just working with the patient to see what is considered affordable so that we can get them up and on their feet.
Okay. And I know that we have listeners not only in Georgia, but in the Gulf Coast and Louisiana and Phoenix and Arizona. So stay with me. Even though Dr. Bhikha is here today from Georgia, we're going to talk about all things ankle and foot. So that pertains to anybody, no matter where you live. And part of what I'll ask him is how to find a good doctor in your local area before we're done. So don't turn that channel. Stay with me here. Okay, so Dr. Bhikha, tell us a little bit about how you got involved and how you chose ankle and foot.
So I did my undergrad at University of Georgia. I graduated with a degree in microbiology. So I knew I wanted to be in the medical field. I just didn't know exactly what. So I actually took the medical school entrance exam, which is the MCATs. I also took the pharmacy school entrance exam, just not knowing what I really wanted to do. Ended up getting into both medical school as well as pharmacy school. And instead, I took a year off from undergrad or after undergrad before I went to podiatry school. Obviously, the parents weren't too happy taking that year off, but really that year taught me more about what really is out there. We're always taught that, you need to be a medical doctor or an MD or, a pharmacist. Those are the ones that we always know of. But a friend of mine who was actually a year ahead of me was already in podiatry school, and doing more research, I realized that, I actually prefer doing more the more finesse type surgeries, the things that are a little bit more smaller in realm.
Fine motor, micro surgeries.
Exactly.
Because you've got to be very attentive and very particular.
Exactly. The foot itself has 26 bones and, over 30 joints. And
we're going to talk about why that scares me and why that's preventing me from getting my situation taken care of.
And these joints are very, very small. So it does take a little bit more of, small motor motions than, trying to replace a knee, where you're essentially using a hammer and trying to put a new joint in. The other thing I liked about podiatry was the fact that it's not just musculoskeletal. We deal with from the skin in. So patients come in with, simple things like athlete's foot or fungal nails, and then they'll come in with things such as malignant melanomas that have never been seen until we identify them and then send them off to a oncologist as well as a dermatologist. So it's a nice balance of being able to work with musculoskeletal. I in particular do sports medicine and trauma and reconstructive surgery as my primary interest. However, I do see patients on a daily basis that have an ingrown toenail or have athlete's foot or fungal nails or neuropathy or diabetic conditions. So it's a nice balance of not ever getting bored.
So we have a lot to talk about today in a very short amount of time.
Yep, of course.
Okay, so again, I'm here with Dr. Shamir Bhikha. I didn't know you went to UGA, so you're
I'm definitely
bred Georgian
exactly
physician.
A bulldog. And I actually did graduate, or I went I grew up in Alpharetta, so I went to elementary school about 6 miles from where I practice, and went to middle school and high school right around that area too. So it's actually interesting to be able to now see patients who were my elementary teacher or were my high school teacher. So that's kind of fun.
And I'm telling you what, that probably goes hand in hand with the whole ankle and foot surgery thing, because there's not a lot of risk taking and going outside the box. You're determined and routined, and that's good. Okay, so but let's talk a little bit about that. Doctor of
Podiatric
medicine. Right. If you've got something going on with your foot, you want to see a specialist.
Exactly. Now with the way the insurance policies work, as well as the way with society works, there's a push to get patients to first see their primary care doctor. And then their primary care doctor will either treat if they're comfortable or go ahead and send them to a specialist. However, a lot of insurance plans actually allow patients to go directly to a specialist.
Well, that's good because we pay every time we see a doctor.
Exactly.
And right now, everything's out of pocket. So
exactly. And so rather than having, two copays of, yes, a primary care doctor as well as a specialist, there are times where you're allowed to go directly to a specialist. And that's a matter of understanding and realizing that, okay, if you have a foot and ankle problem, maybe let's call a foot and ankle specialist first. Call the office. The office staff is always nice and wanting to make sure that patients get to see the right doctor at a quick time. So they will actually call your insurance company and verify to make sure you don't need a referral. If you do need one, they'll actually call your primary care doctor and get that referral, so that we're trying to minimize costs as best as we can.
Okay, and that's a whole nother thing, because in this day and age in America, healthcare is in such a shambles.
Oh, it definitely is.
And I've talked about it on several shows because I'm still not over the one-day appendix that's cost me. When I saw the bill for $38,000,
right, I think
had a heart attack.
Right, and I remember in podiatry school, my second year, when you're in podiatry school, medical school, you don't really take care of yourself all that well. It's a lot of drinking energy drinks and drinking Coke, trying to get as much caffeine as possible, not sleeping and not really eating well or drinking water. And I remember being in a test and starting to have pain along my right flank and not really... I can't get up I want to finish the test. So I'm, struggling to try to find a position, and ended up going to their healthcare center first, then getting sent to a urgent care center, taking a urine test, which took forever because I couldn't even squeeze out any urine, and then being told from that place to go to the emergency room. Spent, I believe it was 3 to 4 hours in the emergency room, ended up with an $11,000 bill from the emergency room, plus a bill from the urgent care center and then the health center at the school. So it's one of those things that it is crazy, and you really don't know who to turn to when things happen, because everyone has their niche and those niches overlap, so that it's confusing.
Yeah, right doesn't talk to left, and anyway. We'll do a whole nother show on healthcare in general. But back to foot and ankle.
Yes.
So what are, and I know this is a loaded question, the typical symptoms a patient comes in and wants to talk to you about? So, why do they finally make that appointment to come see you?
So it depends. We have patients, for example, that have systemic conditions, such as diabetes being the number one reason why we see patients in the systemic world. Most diabetic patients are supposed to be seen by a foot and ankle specialist either every 3 months, depending on if they have already had complications such as amputation, neuropathy, things like that, or they're at least supposed to see a doctor once a year for a overall annual foot screening. Then we also have patients who are what we call the weekend warriors. Those are the ones who really don't do much conditioning Monday through Friday. And then, for example, we were in the World Cup this past month. All of a sudden, we have a lot of soccer injuries because people want to go outside and kick the soccer ball. They never kicked the soccer ball for the past 4 years until the World Cup came, and now all of a sudden they're soccer players. Same thing happens near the football season when you start seeing on Sundays, Saturday and Sundays, these pickup games, or basketball, for example. So we get these sports injuries, and usually Monday morning is our busiest day because Saturday, Sunday they hurt themselves, and on Monday morning they're calling for an emergency appointment. So patients will come in with obvious injuries. Either they broke something, or they tore an Achilles, or they sprained their ankle. Then we have the patients who are ones who've had pain for months on end, or even up to years on end. Now, it could be either intermittent, meaning on and off sharp pain. It could be one that's just been a generalized ache at the end of the day. And I recently gave a lecture with North Fulton Hospital with the Senior and Rich Living Center. And I told them one simple thing. Your feet are not supposed to hurt. If your feet hurt, that means you should get a doctor to check it out. Just as if you were having chest pain, that's not normal. That's when you would go to the emergency room or see your cardiologist. Your foot is not supposed to hurt. And the thing is if you keep on continuing to allow your foot to hurt, then what ends up happening is you prolong, one, pain, but you prolong the underlying reason why you're having that pain, whether it's arthritis and then arthritis progresses, or whether it's some sort of soft tissue injury such as a tendon tear or a fasciitis or a tendonitis that continues. And what happens is when this becomes, initially it's fasciitis, it's acute inflammation. Over time, you're going to build up scar tissue, and that scar tissue is then going to turn into chronic inflammation and fasciosis. Well, it's easier for a doctor to treat fasciitis. It's much harder to treat treat a patient with fasciosis. And also, your body forgets about it.
Okay, folks, this is Jeannie Pete. And 3 years ago, I think I had plantar fasciitis. And 3 years later, I can't walk when I get out of bed in the morning, and it's probably fasciosis. So I've gotten myself into quite a predicament here. Right.
And, it's one of those things that, yes, we can still treat patients even 3 years out, 5 years out. It's not one of those things that, you're 5 years out, we're going to have to go straight to surgery.
Okay.
Well, we were always trained, and majority, actually, I would say all my partners are conservative care first, then surgery. Now, obviously, if you have a bone sticking out of your skin or you broke something that's with your foot in the wrong direction, we're going to take you straight to surgery. But a lot of these conditions can be treated with conservative care. For example, fasciitis. Fasciitis is one of those things that stretching is the number one reason why patients continue to have pain. They don't stretch enough. People will go on WebMD or they will go on to Wikipedia and they will try to self-diagnose themselves. And that's great and all, but there was actually a recent article out from the Journal of, I think it was, Journal of American Medical Association. And it was also posted on CNN and all the other news sources. But 9 out of 10 medical entries in Wikipedia is wrong. So patients are going into these sources and they're self-diagnosing themselves, and then they come to the office and they already know they have fasciitis. And if you do not match up
with their... What you don't know, this is exactly what I said to the doctor this morning when I met him.
And what happens is they match, once they're set on that diagnosis, if you go off that diagnosis because you see something totally different, they won't believe you or they won't be as compliant. And even with fasciitis...
Let's talk about what is plantar fasciitis.
So plantar fasciitis is inflammation of the plantar fascia band, which is a band of tissue that essentially starts from the heel bone and goes to your forefoot or where your metatarsal heads is.
Is it in the middle of your heel
so
or
there's
is it
actually
on the
three
side?
bands.
Yeah.
There's 3 bands. So there's a medial band, a intermediate band, and a lateral band. So essentially your whole arch as well as even the lateral side or the outside of your foot has this band. Now, usually the common ones are the 2 middle bands, or the central and the intermediate, or the medial and the intermediate band, because that's where your arch is. What I tell patients is that, just because you have plantar fasciitis, the condition is actually much higher up, and it's in the calf muscle. Your calf muscle is made up of 2 muscles, the gastroc and the soleus. Now, these 2 muscles make up a tendon called the Achilles tendon. And we all know that the Achilles tendon inserts into the back of the heel bone. But the fibers from that tendon actually then go down and
like
move
fingers.
forward, exactly, and help form the plantar fascia. So if your Achilles tendon is tight, then your plantar fascia is tight. Now, what happens is these patients will sleep just like we all sleep. We don't pay attention to how we're sleeping. And we sleep, if you have a tight Achilles tendon, exactly, your foot is going to be sort of plantar flex, and your arch is tight. And what happens is as soon as you wake up, you put your foot down. You haven't stretched whatsoever. And now you get a sudden stretch in a plantar fascia band that's already tight as it is. Or you get a sudden stretch, and you usually get both. You get a sudden stretch in that Achilles tendon. When these two things happen, you start to develop micro tears within the plantar fascia. Now, as you walk a little bit, the intensity of the pain, so when you first put your foot down, it may be 10 out of 10, the intensity goes down to maybe 5, 6. It may not ever go away completely, but as you walk...
For me, it's not anymore. I can feel it sitting down.
Right, and I think what the issue now is because you start developing scar tissue. But as you walk, this plantar fascia band, as well as the Achilles tendon, will start to stretch a little bit. But most of these patients either have some other underlying issue besides just tight Achilles tendon. They either have a high arch, they have a flat foot.
A very high arch.
Exactly. So now imagine a rubber band, and you look at a rubber band very closely, and as you stretch it out, you can see the small little tears there or the little cracks that occur in that rubber band. That's how your plantar fascia is acting every single time there's nothing underneath it to support it, i.e. a insert. We've had patients who will go to Walmart.
Yeah, they don't work.
Target, exactly. And
I've tried that.
Right, and the reason why it doesn't work is because those inserts are soft. Now, all of us have weight, and we also all have gravity pulling more of our weight down into the ground. So how is a pillow or a gel cup or anything else supposed to support our weight and maintain that arch? That's why patients will spend $300-$400 in inserts all over the place. Then they'll come to the doctor's office with that bag full of inserts and start showing us, this is what I got, this is what I got. And really, it's the need for an orthotic, which is different from a shoe insert, which you get in a
And
Walmart
are those shaped to the person's feet? Are they customized or no?
Not necessarily. You don't have to have customized inserts.
Okay.
My office, for example, 99% of my patients do not have custom inserts. They have what we call prefabricated orthotics, which means that they're made for mild to moderate deformities, made for the general population.
Okay.
And we can use them either for plantar fasciitis. If they have high arches, we'll give them a specific type for high arches. We'll give them some that can fit into dress shoes because dress shoes are actually tapered up front. And then there's that population that either are set in their mind that they want custom inserts, or two, they really need custom inserts because we just cannot control their pathology with a over-the-counter or prefabricated orthotic. Those are the ones that are actually casted. We in our office still cast with plaster because we get the best imaging or best feel of the foot with plaster. Now we do have those laser machines that can actually laser or 3D scan the foot.
That's
things
so
like
cool.
that.
Yeah.
And they work just as well. But I, in particular, even though I was trained to be able to do the casting and things like that, I don't do it on a day-to-day basis. So why should I, allow patients to come to me for that? I will have my patients seen by our pathortist within the group.
Yeah, because they're the specialist.
Exactly. The pathortist will cast them for that. And what I like about it is the pathortist does on a day-to-day basis. Just like I wouldn't ask the pathortist to do surgery, I shouldn't be, doing their casting because I think the pathortist can do a greater job.
And that really does help. You don't need surgery. Just wearing those inserts can take the pain away.
So the inserts is one thing because we're supporting the arch. Therefore, we're supporting that plantar fascia band, and we're not allowing that band to constantly overstretch.
Is there a way to fix it, or is this a lifelong thing now?
It's one of those things that, if we're going to go the conservative route, you should be in some sort of insert. To be quite honest with you, majority of the population should be in some sort of insert. It's just because it's healthy living. It's being able to maintain the foot shape the way it is to help prevent abnormal pressures on various joints, therefore hopefully decreasing how much arthritis develops later on in our life. Also, not just inserts is the cure for everything. You have to have proper shoes. I, for example, saw your shoes. Oh,
come on now.
I know. I saw your
shoes. It's summer. We're women.
I saw your shoes when as soon as you told me that you think you have plantar fasciitis. And you know what?
I can't wear flats.
And there's a reason why you can't wear flats. Because if you wore flats,
I have high
then you
heel
would have,
cork heels on right now.
Right. And the thing is, if you wore flats, you would have a overstretch of that Achilles tendon. Therefore, you would have pain.
I've noticed that.
Right.
If I wear flats or go shoeless, it's far worse.
Exactly.
So now I wear a lot of heels.
Right. And
even heel flip-flops.
Flip-flops. Right. And it's because you're essentially forcing that Achilles tendon to stay contracted because you don't want that tendon to stretch. Every time that tendon stretches, you're having pain.
Right.
But in the long run, wearing high heels and things like that also hurts your ankle. Patients can develop bunion deformities much quicker.
Which I have.
They can develop arthritis in that first MPJ, which is that first big toe joint. They can develop progressively worsening hammer toe deformities. All these kind of things can.
Thankfully, I don't have that.
But it's one of those things that
Pete's
patients can develop even longer in their years. I remember having a patient, and she actually never came back after a couple of visits. And the reason why is that she still is in the sales business area of expertise, and she's always been on trade shows and conferences. And
you're not going to get her to change her shoes. I'm going to tell you that right now.
Exactly. And she wears high heels for the past 30 years. Well, imagine your foot in an incline of so many degrees. And as we all walk with a sort of forward propulsion, which means that our foot slides forward in a shoe because momentum pushes us into that shoe. Well, if you're at an incline and your foot's sliding forward, you're jamming in the front of that shoe. And in particular, if you're in a high heel, you're jamming at a certain angle. Well, she over time started to develop arthritis in those two big toe joints because your big toe joint's always been in this sort of abnormally elevated position. So she starts developing arthritis in the joint, and at a certain point of time, there's not much we can do. We can either clean up the joint, which is a temporary fix, but if you don't change your shoe gear, you're going to go right back to it. We can do joint replacement surgeries now.
Oh my goodness.
Or we can fuse your toe joint. Either way, when surgery...
None of which sounds appealing.
Right. And when surgery becomes a factor in, things, you end up starting to develop swelling. I tell patients right off the bat that any kind of surgery I do on the foot, they can have swelling afterwards because gravity is going to pull fluids down. And, for example, we do a bunion surgery.
I hear that's horrible.
Right.
I hear that's just the worst surgery.
And the thing is that majority of my patients don't even have pain after surgery, and the reason why is that they follow the protocol of rest, ice, and elevation.
I had a friend, and she said it was not a problem at all, but
Yeah.
I heard that's just a nightmare.
And it definitely can be. It's one of the things you have to obviously find time in your life to make sure you have the ability to take care of yourself.
I want you to hold that thought because I think we need to delve into this in greater detail, but gosh, there's just so much related to the shoes we wear. I'm already hearing plantar fasciitis and Achilles tendon pulls and hammer toes and bunions and arthritis and joint PC. I am listening. And, everything we hear, so much of your well-being, we could even take this to another level because I get all excited about this stuff, but has to do with your feet. I mean, if you look at like acupuncture and chiropractic and all those little bones and everything, in ancient worlds and in other cultures, they think so much of what happens in your whole body is related to your feet. And we're not taking care of our feet.
It's true. I mean, I give lectures quite a bit at various schools and universities and things like that. And one of the things I always remind them is just because we're foot and ankle specialists doesn't mean that we don't look at the whole body. We're one of 4 different types of doctors in the U.S. that actually has full prescription privileges. We're not limited in what kind of prescriptions we can write. I mean, as long as you stay within your scope. But we don't have limitations in terms of surgeries as long as we stay within the foot and ankle. And there's been times where a patient will come into the emergency room with a ulcer on the bottom of their foot, which is essentially a soft tissue skin infection with an opening. And they could be as healthy as 43 years old, and they never knew they had diabetes until they came to the emergency
and then
room.
you're looking at the bigger picture. We have so much more to talk about. I do want to go talk more about all of the ailments of the foot and ankle, so stay with us. We have to take a quick break. We'll be right back. Hello, I'm Jean Pete, and I welcome you back to our show, Better Living. Better Living is brought to you by the Homestead Hope Foundation and is sponsored by Homestead Hospice, where commitment to education and premier hospice care helps patients and families through life's most important journey. Thanks for staying with me. I'm Jean Pete. I'm still here with Dr. Shamir Bhikha of Ankle and Foot Centers of Georgia. I did want to just give you information on how you could get in touch with Dr. Bhikha. And that is phone number 770-559-0348. You can also go to their website at www.ankleandfootcenters.com. And he's right here in Alpharetta, but there's 21 centers all over Georgia. So please go to their website if you have anything ailing your foot or ankle. Prior to the break, we talked about mostly the foot. Plantar fasciitis, tendon issues, Achilles issues, how it's involved with your calf muscles, bunions, arthritis, hammer toes, and all things related to wearing really cute high heel shoes if you're a woman. But I do want to delve a little bit more into the surgeries and how that all works, or the procedures. It may not be a surgery. So like for plantar fasciitis, you had mentioned you can wear an insert. Mm-hmm. You can also, I hear, wear something when you go to bed that will keep your foot extend.
Exactly. It's called a night splint. The thing is that majority of, we all heal at night because that's the one time the body's at rest. So even those little micro tears that develop in plantar fasciitis are healing at night. The problem is that we don't heal in just one night. We try to, but we can't. And we will put down a temporary scaffolding of various cells to try to fill in those little tears. Problem is that we heal right back in that contracted position, in that tight position. And the whole point of a night splint is to put our foot at 90 degrees and allow that plantar fascia to heal in a stretch position so that we don't have this constant issue of reoccurring tears. Also, it helps in the fact that you're stretching at night, not even thinking about it.
So when you put your foot down on the ground, it's not a shock to the system.
Exactly.
Because you've been doing it all night long.
All night, exactly.
Now, does it affect sleep, though?
It can. What I usually tell patients to do initially is wear it while you're watching TV at night.
Before you go to bed.
Exactly, before you go to bed. And slowly bring it into the bed. I've had patients who have said that they put it on the first night and they can sleep all 8 hours. It feels great.
And how long do they typically have to wear the splint before they're fixed?
Right. Initially, I tell them to wear for the first 6 weeks, no matter what. And then, until we get complete resolution of symptoms, or at least 95% resolution of symptoms. They never throw away their night splint, though.
Folks, here's the deal. I've been suffering for 3 years. You've listened to me. I'm going to say it again. I walked off 70 pounds about 3 years ago, and it was the best thing I ever did. However, I didn't wear good shoes. My sneakers were very old, and I couldn't let go of them. I don't know, it was some emotional thing. I was losing it with my old sneakers, I guess. I don't know. Here we are 3 years later. I literally have been suffering with this for 3 years. Stupid me. This is why I'm a radio show host, and I have the privilege of bringing experts to you in the community so that you don't act like me. So if you have an injury, if your foot has started hurting, if your heel has started hurting, go to the doctor, because all it would have taken me was an orthotic and a splint, probably.
Yeah, initially it would have been orthotic, proper shoes. We would have argued about that.
That wouldn't have happened.
Well, we would have argued about it. There are even flip-flops that have arches built into them. Vionic is a great brand, and they have what's called OrthoHeal technology. Thing is that we don't see that out in the stores, and therefore we don't believe it exists. However, it's on Home Shopping Network because I've seen it at 2 a.m. when I can't sleep. So I do know that they actually sell those Vionic sandals on that, and they are cute. It's funny because I carry these brochures in our office because in Alpharetta, just the fact that I'm in the burbs of Atlanta, I see patients who will not listen to me when it comes to proper shoe gear. That's completely fine. We have to adapt to that, and we find ways of still getting our point across and letting patients wear what they need to wear to feel cute or wear it to work, etc. But at least they're taking care of their feet.
Okay.
So there's always that option. Then stretching. Stretching is the biggest thing. We have patients, or me in particular, have patients that stretch twice to at least 3 times a day. And that's in the acute setting of pain.
When you get to the point where I'm at, you have to stretch all day long because it's painful. Even sitting, I'm always going like this.
Exactly. And the
because
thing
you
is,
have to.
Right. And the problem, though, is that stretching isn't routine. It's not a consistent thing. What we try to get patients to do is be more consistent. It's like saying, I'm going to go work out, and then you're sitting here with a dumbbell at your desk. And you do 5 minutes one day, you may do 10 minutes the next day, then you may do only 1 minute the following day. We're trying to look for more consistency. Weight loss is important in any kind of foot ailment, just because of the fact that, we all have weight, and we have gravity
pressure.
putting more weight. I mean, think about it. There's 26 little bones trying to keep your foot up, or keep your whole weight up, sorry. So it's one of those things, even myself, I was 68 pounds overweight a year ago.
Good for you.
And I lost 70 pounds in the past year. One, because it's kind of hypocritical for me to tell patients to lose weight when if
Do you
I'm
walk it
overweight.
off?
I did a lot of cardio.
Good
a lot
job.
of actually weight training, because weight training actually burns more calories.
Yeah,
than
you
cardio
men make
does.
me cringe, though. You have an easier time.
So yeah.
But yeah, that's great. Good for you.
And the same thing, I noticed I sleep better. And my feet don't hurt either. It's one of those things. I have patients always tell me when they're in the office, well, can I wear what you're wearing? And the answer usually is no. Because, one, I'm wearing clogs that I can put into an autoclave machine because I get blood all over myself. They don't have that that worry. So it's one of those things that just because someone else is wearing it doesn't mean you should be wearing it. And we get that a lot.
It's what's right for your foot, your shape, your arch, your width, how you walk.
Exactly. And
where you put the pressure on your feet.
Right.
I'm a heel walker.
Right. And I'm not one to push different brands, because we're doctors. Our whole goal is to look at research, look at evidence-based medicine, and come up with a solution.
Okay. So thank you all for listening to my issue, which is plantar fasciitis. But we have so much more to talk about. Let's talk about bunions, because, the older we get, the more pronounced they are. Are they harmful? Is there anything other than what we hate the look of it? Because your toe starts to angle in.
Right.
Is there a danger in not taking care of a bunion?
So a bunion deformity is one where the first metatarsal, which is the big, or it's a long bone that makes up your forefoot, starts to go outwards, and the toe itself starts to turn in the opposite direction. What ends up happening is, you can develop a bunion deformity. Bunions can be seen in children, in their 15, 16, 17-year range, or it can be seen in their 30s, 40s, 50s, and onwards. We don't treat every single bunion. There's patients who can have a bunion that's what we would consider severe, but they've adapted to it. They wore wider shoes. Right. They wear shoes that are wider, that don't cause friction in that area. They wear they don't ambulate as much as
it's not a priority to them.
And it does become a priority. I always tell patients that I'm not a cosmetic surgeon. I don't do things for cosmesis purposes. If you're bothered by the bump, you may need to find another doctor, because.
But sometimes it can hurt. It can feel kind of arthritic.
Right, and that's when we would treat it. For example, if patients are not able to wear the type of shoes they need to wear. Now, we're talking
because you can feel it rubbing.
Exactly, and we're talking reasonable shoe gear. Not okay, I can't get into my 4-inch stilettos. Try something different. But if they are having issues with certain shoe gears, they're having pain on a constant basis because that area becomes inflamed and turns red, and it's very tender to touch.
And does that then become into a chronic arthritis situation?
It does, because you're obviously, when the toe turning in one direction, the joint is now not evenly being utilized. It's being utilized on one end versus even amongst the whole joint. Therefore, you can start to develop arthritis. And that's when patients will come to us, because they're having pain with all types of different shoe gear. They're having pain with just walking.
And that's a high-pitched, sharp pain. That's not comfortable at all. And you need your feet to walk.
It's not, right. And those patients are the ones that, we would first still try conservative care, whether it's using moleskin and we put it directly over the bump so that it doesn't rub in the inside of a shoe. We get them to look for proper shoe gear. A lot of patients, especially flat-footed people, and the majority of the population is flat-footed versus a high arch. And people who have bunions and other kinds of abnormalities will try to shove themselves into a Nike tennis shoe. Nike tennis shoes are the narrowest type of tennis shoes that you can find. They're very narrow up front.
Yeah, they are.
And the reason why Nike does well is because, of course, they have great endorsements. They have athletes. They have people who market their brand very well. But that doesn't mean that they themselves don't have special shoes. A lot of these athletes have special formed Nike shoes for their foot. So people have to realize that
the travesty.
Exactly.
We are pawns in the marketing game.
Exactly. And your foot may not belong in that shoe. Most of my patients, if not all my patients, once they actually see me, are in either a New Balance or an Asics
I
brand
heard
shoe.
Asics is awesome.
Right.
I'm telling you what, the guy at Dick's told me that. Asics is the best shoe for walking, jogging.
Yep.
Yeah.
And New Balance is amazing also because of the fact that New Balance has shoes that are designed for particular conditions.
I will have you know my new sneakers are Asics.
There you go. Perfect. Now, does that mean that you don't need an insert inside the shoe?
Yeah, I probably do.
No, you still need an insert inside the shoe, but the overall integrity of the shoe has to be sufficient. It has to be a semi-rigid type shoe. I do this test with patients all the time because they come in with the craziest types of shoes. If I can turn your shoe into a burrito, imagine what your foot does in that shoe.
I'm picturing my sister's flat flip-flop.
Yeah, and
You just fold
bending
it.
Exactly.
Yeah.
And this is something that I don't just do with my patients. I do it with my parents. My dad's a diabetic, and he himself, developed a small little wound on the back of his foot. He went 6 weeks without even telling me. He told my mom because my mom would see him, limping around, and within 3 weeks after I actually found out, it was gone because we were able to take care of it.
Yeah, and you don't want that to get ahead of you.
Exactly. So it's one of those things that even with bunions, you have to recognize if it's hurting, go see a doctor. If it's not hurting, then we can do things.
So I have to think. I can only go by experience,
Right.
and experience is my own personal experience. But I have to think I'm not the only one in the world that's scared to death of foot doctors because there are so many bones and tendons and whatever else is in there. And it's scary, and you hear horror stories. You can get a shot of cortisone, but there's so much in there they can hurt you for life because they didn't do it right or whatever. So there's a fear of messing it up even worse.
Right.
So how do you handle that?
The thing is that obviously anything, whether it's a simple thing as an injection versus let's say we're doing an ankle fusion, everything has a risk to it. Now, obviously, an injection is a little bit less of a risk compared to an ankle fusion, but injections themselves do too.
But even with the injections, how do you know exactly where to go?
It's based on anatomy, and that's the reason why we want specialists doing it rather than a primary care doctor or something like that.
And are they looking at a screen now and the inside of your... No.
For example, if I was to right now...
I will be making an appointment with Dr. Bhikha after the show.
If I was to, for example, just do a quick squeeze, I would know exactly where to squeeze to elicit your plantar fasciitis, and that's because it mainly starts right at the origin of its on the heel bone. So we know exactly where to push. We also know what depth to go at. We can feel with the needle the plantar fascia because you can feel it strumming like a guitar.
Wow.
You can sort of strum on it. And the thing is not more of the surgery or the injection being the risk. Cortisone itself has a risk. There's a reason why we limit to just 3 to 4 cortisone injections in a particular area in a year's time. And that's because cortisone has negative impact. In particular, the plantar fascia, it can cause plantar fascia ruptures with repetitive injections into a particular area. It can cause the fat pad, which is the heel. Remember, the heel has a lot of fat to help with shock absorption. Cortisone can cause fat atrophy, meaning the fat pad itself starts to disappear. It can cause soft tissue, which is the skin, or the underlying skin to start to necrose or die away. That's why we don't do repetitive injections. In general, I don't even offer a cortisone injection unless you're 10 out of 10 pain.
That's
because you're
good.
not going to get a benefit from it.
That's good.
If you come in with 5 out of 10 pain, I give you an injection. Next time you may say, I have 3 out of 5. Or 3 out of 10, sorry. That's not going to be a steep improvement. I look at injections as a Band-Aid. They're not a cure. They're a Band-Aid to treat symptoms so that what's going on underlying is our main focus.
I wouldn't advocate for it. I don't know. I'm just...
And you know, even for you, if a cortisone injection is what I need to get you to start doing the stretching in that because you're in so much pain you won't do the stretching, then that's what the cortisone injection is for.
Yeah.
But then after that, we still need to do stretching in the shoes and all that kind of stuff.
Okay. So let's not talk about my issues anymore because I want to help everybody else. But bunions. Say someone does come in and have a bunion surgery. What do they need to know about recovery time?
So bunion surgery is not standard. It's not a cookie cutter procedure. Bunion surgery is based on the degree of deformity as well as the person's bone density.
Oh, okay.
Density, because some people are osteoporotic. It's also based on age. It's also based on the ability to be non-weight bearing, meaning not putting weight on it whatsoever for a couple of months versus a couple of weeks. It depends on what is needed. If you have a severe bunion deformity, we can't do that standard cut in the head of the bone and move the bone over. We have to actually either fuse the joint or do a much more significant procedure.
So again, get it done earlier.
Well,
Don't wait too long.
Right, and the thing is though is that there's some literature out there that says that the bunion can progressively get worse. There's also literature out there that you have a bunion that's mild at age 15 or 20 or 30, and it may never get worse.
Okay.
So
you really
there's
don't know.
No rhyme or
you
reason
gotta get
for
looked
it.
at.
Right. And if you have a bunion at 15, 16, 17 years old, well, that bunion is caused by laxity, which means that the procedure choice is different. So there's no such thing as a cookie cutter bunion procedure.
Okay.
Some bunion procedures can be as simple as moving the head over. Those procedures, in my practice, they are non-weight bearing for 2 weeks just so that the incision itself can heal nicely. I don't want we tell patients to be partial weight bearing or weight bearing in a boot. They overdo it because they're not feeling any pain because they're either on pain medications or they're icing every so often. What happens though is they get swelling, and that swelling causes that incision to have pressure and it can gap open.
Yeah, that happened to me.
And then you get a scar. Mm-hmm. So for 2 weeks, we have them just not put weight on it whatsoever. And we advocate, baby yourself, keep your foot up, ice it, etc. And we've noticed that when you do that, you don't take as much pain medication, which is great because then you're at least coherent and able to do other things. And then after 2 weeks, we take the stitches out, or we let the stitches absorb, depending on if we're using absorbable stitches or stitches that are ones that need to be removed. And then you're weight bearing in one of those boots that you've probably seen, people walk around
in. Yeah, we see those a lot.
It looks like a ski boot almost. Mm-hmm. They walk in that for an additional 4 to 6 weeks, just so that the bone, it can heal. When we make bone cuts and we move bones over and things like that, we put 2 screws or we put, a screw and wires, etc., to hold things in place. And at that point, it's just a matter of letting your body heal. The biggest things that we see with bunion surgery afterwards are, you can see soft tissue skin infections where the incision becomes infected. But the things that we see the most is swelling. Gravity always pulls fluids down. Therefore, the foot is likely to swell after any kind of surgery or any kind of injury. And I, in general, tell patients that for the first 3 months, expect swelling because swelling is common. Mm-hmm. And it's going to be seen in a foot surgery. But I learned this from residency from one of my attendings during residency, that for every decade of life, add an additional month. And now this is not a clear-cut rule, but it just allows to get a better grasp of things. So if you're in your 40s, then go ahead and add an additional 4 months. So we're looking at maybe about 7 months of swelling. But you can have swelling up to a year, and that's what's the main problem with patients afterwards, is that they are discouraged by the swelling. My main goal is not more of the swelling as much as the bony prominence that was causing the pain is gone. Mm-hmm. And we don't just shave the bone off.
And it's going to get better. You just got to get through it.
Exactly.
Yeah.
And the goal is not to shave the bump off. Shaving a bump off is not going to cure anything. We have to look at the underlying reason why you're having a bunion. That usually has to do with that angle where that metatarsal is swinging out. Mm-hmm. So you have to actually move the whole bone over. You don't just cut the bump because then the bump's going to regrow again. Mm-hmm. So we have to actually cut the bump, then swing the bone over and put it where it's supposed to be.
Wow. Okay. So let's talk about diabetic neuropathy and some of the other. We're not going to get to ankle issues. We'll do another show on ankles.
Of course.
How's that? You'll have to come back.
No problem.
Let's talk about, because this is better living and it is geared towards seniors and their loved ones. And as we age, more and more of us are diagnosed with diabetes, and we also have more and more issues. So what happens with diabetics in the feet, and what can they do? So
if you're diabetic, whether you think you're the most well-controlled diabetic in the world or you are a poorly controlled diabetic just as in denial, you should see a foot and ankle specialist at least once a year. You want to be able to have someone keeping an eye on your foot. As diabetes progresses, there's other issues that can develop. You can have eye complications. You can have complications with your kidneys, and you can have complications with your blood vessels and your nerves. Now, with neuropathy, essentially the way I describe it to a patient is neuropathy is one of those things where if you were to look at an electrical wire out on the road, and imagine, especially in Atlanta, when we get those ice storms, having ice all around it, the signal that's going through that wire isn't as fast as it would be if that ice was gone. Well, imagine your nerves doing the same thing, and the outer layer around the nerve, which is serving as the insulation to allow that signal to go back and forth quickly, becomes sugar-coated. Diabetics, the way I describe everything to them is that imagine all your cells being candy-coated. So why does it take you a lot longer to heal versus a person that doesn't have diabetes? Because your healing cells are candy-coated. Therefore, they don't function as fast or at all compared to the person that is healthy. So when patients have diabetes and neuropathy, we want them to be seen by us because we want to start getting them to, one, be cognizant of their foot, because foot ailments that are left mistreated or untreated can lead to bigger issues. And we want them to also realize that they are the best tool for prevention. We can only do so much, but we're not going to come to their house every single day, wake them up and look at their feet. That's something that they should be doing. And we give them the tools so that they can do that.
And what are some home things that they can do? Because like we talked during the break, when you're a diabetic, it is so important that you're moving your body and that you're getting the oxygen through your body and that your cells are breathing well and that your weight doesn't get out of control, because all of those things lead to more problems that when you're diabetic, you have a higher percentage risk of getting, like heart disease and other things.
Right. I mean, the thing that we always tell patients is that, look, you should never go barefoot at home if you're diabetic. Okay. Because you're likely to step on something. If you have nerve issues, you may not know that something's too hot. We've had patients that have walked on concrete and burned themselves, causing second and third degree burns of their foot because they could not feel it. So we have them always wear socks and always wear shoes, indoors and outdoors. If you're a diabetic with neuropathy, Medicare as well as any other insurance company will pay for you to have diabetic shoes with those special inserts because they want to prevent you from developing wounds.
Wow.
We also want them to moisturize their feet. We in particular use a thing called Idonia cream. It's specifically made for diabetics as well as for other ailments. But we want them to moisturize their feet because if you have dry skin, that dry skin can lead to cracks. That cracks can then lead to an opening that leads to an infection. So we want them to moisturize their feet. The problem that with that, though, is that they start to put cream in between their toes. If you put cream, any kind of lotion in between your toes, it's not going to allow it's not going to dry. And just like if you spend too much time in a shower where you get that white, wettish skin, that's what's going to develop and you end up getting cracks leading to infection. So these are all the different things that we try to tell our patients when they come in so that we can prevent any kind of further injuries.
The best medicine
damage.
is preventative
Exactly.
medicine. And just being educated as to how you can do that. And just being an advocate for yourself. Once a year, if you're a diabetic, you really should get your feet checked.
Right. And then, at that point, we'll tell them, hey, you're a diabetic with neuropathy. You shouldn't be cutting your own nails. You should have us seen.
Well, thank you so much for coming today. Again, we didn't even get to the ankle side of the foot and ankle business, so we'll have to have you back and we'll do a whole show on ankles. Again, this is Dr. Shamir Bhikha with Ankle and Foot Centers of Georgia, and you can reach them at 770-559-0348 or go to their website at www.ankleandfootcenters.com. I'm Jeannie Pete. Thanks for listening. Have a blessed day and week ahead, and listen here, same time next week and every week. Homestead Hope Foundation is your resource for a healthy life. God bless.